So this masterclass came about because so many of my patients were asking me about reflux disease. And I figured, you know what, I might as well do a masterclass and teach a little bit about what I have learned over the years. And over the years, as a gastroenterologist, trying to understand reflux has been difficult. You know, in medical school and in GI fellowship, we kind of just say, give a PPI and, you know, acid, but it's so complicated. I learned that it was so complicated. And so I'm not surprised if some of you are having challenges with acid reflux. I'm not surprised if some of maybe your patients, I know there's some nutritionists, some dietitians, some functional medicine experts joining us today, are having challenges. I get it. This masterclass is really designed for patients. It is really designed as a good and reliable resource from a gastroenterologist who also loves everything that's holistic and functional medicine, to really share what I've learned over the past decade or so about the impact of functional, integrative, root cause medicine when it comes to reflux disease, and also a personal journey of mine, because I had struggled with reflux for a long time. So I was always wondering, you know, how do I fix this without the use of medication? So we are going to discuss root cause. We are going to discuss some solutions for lasting relief. We are going to discover a few secrets for staying med-free. I'm not going to go into the nitty-gritty of supplements, because all you guys, if you put it in ChatGPT, if you're using artificial intelligence, you can get a lot of that information. But a bunch of supplements is not the solution, and we'll discover why. Okay. So welcome to the masterclass. Some statistics just to put out there: 1 in 5 people suffers from reflux disease. That's a lot of us. More than 50% of the people who are prescribed a PPI continue to take them long term. This is a problem. And this is a problem I wanted to address because I think that is a statistic that is totally reversible. Okay. So this is me, and just want to do a little intro about myself. That's my daughter, Hannah. She's 10 going on 30. And you know what she said to me? She goes, "You're doing this masterclass on a Sunday? What's that about?" You know? So I'm a board certified gastroenterologist. A Sunday is a perfect time for me to provide education for my patients. I trained at the University of Geneva in Switzerland. I did my fellowship training in gastroenterology at Johns Hopkins in Baltimore. I'm a certified physician with the Institute of Functional Medicine, which means I have completed all the trainings, done all the testing, passed all the tests, and I am now actually faculty with the IFM on the gastrointestinal module, and also soon upcoming the annual conference for Institute of Functional Medicine. Over a decade of experience in private practice in general gastroenterology and liver disease, and I speak on a number of topics. One of them, my favorite, being SIBO, and then food sensitivities, gut microbiome issues. I'm diving deep into gut-brain axis disorders because I think we hear a lot about that, but we don't know too much. Do quite a bit of clinical research in my office, so really hardcore clinical research with diagnostic research, as well as new therapeutic medication research as well for our patients with cirrhosis. And we have a private Facebook group called Natural Gut Relief, which I'm sure some of you know about. And we share a lot of educational resources. We interview some wonderful experts on that. So I think if you stick around, I want to share as much information as I can. I also want to be available to answer as many questions as I can. So I am from Ghana. So forgive me if sometimes I get excited and my accent switches to my African accent. I'm just saying that happens. Second thing is I get very passionate, very excited about things, and I may get a little bit nerdy. So when I'm getting too nerdy, just type in the chat, Nerdy Asamoah. If this is over your heads and you guys are like, whatever, we don't care about that, just type in Nerdy Asamoah in the chat. And I will remember to dial it down, because not everybody is a gastroenterologist. So I see a lot of patients who have reflux woes because they just are not enjoying life anymore. They feel that they're having this chest pain and throat pain all the time. They are showing up in the ER because they think they're having a heart attack, right? And that's really concerning. It's actually acid reflux. And you have to go through that whole thing in the ER where they're doing an EKG and doing all this testing, and they're like, oh, it's just reflux. And then you're figuring out, you know, when am I even going to know when it's a true heart attack or if it's truly acid reflux? people don't feel comfortable after eating. So there's huge discomfort with meals and even beverages, like what do I drink? And then there's a frustration of not knowing, why is it happening now? Why is this happening to me now? Or why does it keep happening? When you go in, when you sleep at night and you've got acid reflux and food is literally refluxing into your mouth, you cannot sleep. So that also affects your sleep, affects your quality of life, and makes you tired the next day. So these are some of the clear and distinct woes I hear from patients. And then there's always a worry about cancer, because we always say, oh, you know, this person had reflux for so long and then they got a cancer in the esophagus. So there's always that, you know, underlying worry and anxiety that, you know, if these symptoms are happening on a day-to-day, am I eventually going to get cancer one day? And that's a question. So very often when I see patients in clinic, their question is, why is this happening to me now? What are the long-term side effects? Because the ER put me on acid blocker medication. My doctor put me on acid suppression medication. Am I supposed to take this forever, Dr. V? And some people come in, they've done everything. They've like, I have tried diet, I have tried herbs, I have tried probiotics, I've tried fennel seeds. You know, there was someone who posted recently on a natural gut relief. They had tried everything that I had in my armamentarium, like literally everything. They were like, nothing's working. And that's where we have to question whether is this truly reflux or not. And then some people are wondering, am I ever going to get off my medications? Am I stuck on these PPIs, this omeprazole, Nexium for life? Can I even try to reduce the dose? Who can guide me in terms of dose reduction? So, you know, my objective today is really to define what reflux is and then talk about root cause, because I don't think the root cause is as we understand it to be, that it's just a question of acid. Just put you guys through some case studies, patients that I have had in practice. And this is what I want to be very different on this conversation today. I'm not going to present just a didactic of this is this and didactic and this is that and this is the definition, but I want to share with you some actual case studies that I've had in my experience and how we found resolution and things to highlight on, because not everyone's reflux is simple and easy. There are so many causes. And I think it takes working with an expert gastroenterologist to really understand what your cause is related to and whether special testing is needed, right? And then secrets to staying med-free, like, you know, what are some of the options and solutions? And this is my promise to you guys today, that at the end of this discussion, I promise to be able to share with you a pathway, a program, a structure that I've put together over years to really help patients, especially patients who are at the brink, right? They're like, you know what, I'm about to go for surgery because I can't take this anymore. Something needs to happen. And surgery isn't always a solution, and we'll see why. So I love to use an integrative functional medicine approach because I think that this approach, beyond the conventional, is what got me to really understanding the root cause of reflux disease. And so this will be new for some, but some of you already know about functional medicine, integrative health, holistic health, and we'll have some expertise there. So we say acid reflux, we say non-acid reflux, we say heartburn is a symptom of reflux, and then the fancy term is GERD. I have GERD, which is gastroesophageal reflux disease. And what are the symptoms of acid reflux and GERD? They're kind of the same. Very often we talk about lifestyle and nutrition tips to manage GERD. So believe it or not, when you look at all the studies, the thing that really fixes acid reflux for most people, up to 40%, is lifestyle and nutrition. It's not medication. 40% of patients with acid reflux, if they change diet and lifestyle, will find resolution of symptoms without the need for medication. So that's an important number to remember, guys. So when we talk about reflux, we know we have a lot of symptoms, and we'll go through that. But really what is physically happening is that stuff from the stomach is coming above the diaphragm into the chest, right? And so this can be acid, it can be non-acid, but it's backing up into the esophagus and causing different symptoms, right? And, you know, we all reflux every day. We all naturally, you know, when you have a belch after drinking soda or a carbonated water, you will reflux. Some of that gas will come up and bring some stomach acid contents with it. And you may have a little bit of chest like burning, but the GERD, gastroesophageal reflux disease, is when it happens all the time. You know, after most meals, you're just uncomfortable. You're having to rely on a medication. And we'll talk about whether acid or non-acid is the main issue. But I've had patients walk into my practice, guys, with symptoms that are just like, is this really acid reflux? So I get a lot of referrals from dentists. I get a lot of referrals from cardiologists, of course, the emergency room. I get referrals from ear, nose, and throat doctors, right? And they can be symptoms as varied as, dental erosions. My teeth, my gums are eroding, and my dentist tells me it's acid reflux. It could be clearing of the throat, or I feel like I have a lump in my throat. That's when we start talking about laryngeal manifestations of reflux. This is beyond just the esophagus, but it's going all the way up here. Ear pain can be a sign of acid reflux, like ear burning, ear pain, ear discomfort. Clearing of the throat, I said, chronic cough. Asthma can be triggered by reflux. Reflux can trigger an underlying asthma that's very mild, right? Very, very mild. We know what we see acid reflux associated with sleep apnea. And that really it is the sleep apnea with the strain on the diaphragm and the strain in the breathing causing the acid reflux. So all of this has to be taken into account when we're working with a patient with acid reflux. It's not always just about diet and supplements. And that's what I really want to be clear on today. But the typical symptoms are like burning sensation in your throat, chest pain that will even get better with nitroglycerin, which is the medication that the sublingual that we give to our patients who we think are having a heart attack. It will also help reflux because it will decrease spasm of the esophagus. And we'll see in upcoming slides, and I hope you guys stick with me to see that, which patients are, what kind of reflux patients will respond to that kind of medication, the nitroglycerin. Trouble swallowing, feel like stuff is getting stuck in your throat, getting hung up, clearing your throat all the time. And then some people just plain old vomit. When I was little, I used to just regurgitate food in my mouth and spit it out all the time. I never told anybody about it, but it was acid reflux. So I've had acid reflux since I was 7 or 8, and the food would just come back up. And as an African child, we grew up in a house where we were eating tons of spicy food and a lot of oily food. We cooked with a lot of oil, and the oil was used to kind of preserve the stews. And I would reflux with that all the time. But I had patients who just come in frank vomiting, like not just like regurgitation, they're like, bleh, like throwing up, projectile vomiting from acid reflux. So these are some causes. And what I did is I gave you guys a questionnaire, and hopefully you get it. And I'm hoping that Zai can post it in the chat for us. Yes, she did. And so you guys can actually look at that questionnaire, download that workbook, and actually fill it up. Tally up your number, and then at some point during the conversation, just type in what your score was. Was it a 40? Was it a 30? Was it a 50? So that we can get a sense about the severity of your symptoms, especially as it relates to other people who say they have acid reflux symptoms, right? So this is an important slide. This is one that I really had to go back to, which many of you will not see, because when you see your doctor, your GI, your general doctor or whatnot, when we talk about acid reflux, they're like, oh, you have too much stomach. It's too much acid in your stomach. Or your sphincter, which is here, your lower esophageal sphincter, which is the sphincter that sits right above the diaphragm, between the food pipe and the stomach, your sphincter is too weak. Know, guys, that this sphincter is just a muscle. It is not really a trap door. There is no actual valve or flap. It is just a muscle that tightens and can loosen. And that muscle can be affected by many things. But this schematic is a nice schematic of the pathophysiology of reflux. It is actually explaining how does reflux happen, not necessarily what is the root cause. Why does reflux happen, right? So you could have your saliva, you could maybe just not clear saliva very well, and that could be backlogged. But there's a cause for this, and that's what we have to identify, right? You don't clear your esophagus, so you swallow, and things just kind of linger. Things linger, like you drink a beverage, and things just linger in your esophagus. The motility is not working. That's an explanation, but it's not the root cause, right? And then you have impaired esophageal mucosal defense it basically means leaky esophagus. You've got in your esophagus, the cell lining is inflamed, the barrier is disrupted, and everything you eat seems to be attacking your own cell linings, right? That's what we see in our patients with eosinophilic esophagitis. They have a special type of reflux, really directly related to food intolerance. Then you've got the famous one, the LES, that sphincter that is weak. That is an imaginary sphincter, guys. It's not the cause for everybody, right? And then we have patients who have a hiatal hernia. You have a little bit of your stomach that actually sits right above the diaphragm, like almost like a little bulb. And so that acid is just sitting above the diaphragm and constantly refluxing up and down. So that's going to give you symptoms in some patients, not all. And then you have some people who just make too much acid, just way too much. They're just high acid producers. But the reason is why? What will cause that high acid production? What is the root cause, right? Then you've got some people who just don't empty their stomachs very well. For whatever reason, at some point in time, the stomach is not emptied well. It could be a medication. It could be an infection. COVID did this to a lot of our patients, right? And the same will apply for after food leaves the stomach and it's trying to clear out of the small bowel. It just doesn't clear very well. That's another area that reflux can happen. So this, guys, 1, 2, 3, 4, 5, 6, 7, 8, 9 different causes, actually different pathophysiological mechanisms as to how reflux happens. But generally when we see our doctors, they're like, a stomach acid, you got to cut it down, and then you got to eat less and whatnot. But it could really be related to one or all of these, and these are all very hard to test. But one thing you'll see that they have in common is they have shared etiology, shared root causes. We can always see almost like a systemic way to look at this and understand what's driving this. And that's what we do in our program. That's what we do in functional medicine. So in terms of conventional approaches, someone comes in to see me, I have some heartburn, it's burning. By the time most people have showed up at my office, they are already on an acid blocker medication. Why? Because it's the easiest thing to start. It's easy to start. ER will prescribe it in a heartbeat. You can get it over the counter, right? Walmart, CVS, you could just go pick Costco, pick up bundles of it and start it, right? And according to a lot of insurance companies, they actually want you to try an acid blocker medication for 8 weeks before doing anything else. Go figure. The insurance company mandates that before we even do anything else, that we've put the patient on an acid blocker medication for 8 weeks before they will even approve us, meaning give us a prior authorization to scope or do any additional testing. Now that is, I have an issue with, right? That I clearly have an issue with. I wish they would tell us, the patient can benefit from 8 weeks of nutrition coaching, lifestyle coaching, paid for under the insurance. If that doesn't work, then try the acid blocker. If that doesn't work, then proceed to EGD. But it's the first line. And that's some of the issues we have with conventional medicine, right? That's some of the issues we have. And I do both, but some of this is dictated by insurance companies. It's helpful to check for a bacteria that can exist in the stomach and cause dyspepsia and symptoms very similar to acid reflux, especially if it starts right away. And even if you've had reflux for a long time and you notice that, wow, my reflux is much worse, check for H. pylori. And there are other tests that we do, barium swallows to see if there's a hernia, endoscopy. We want to get pathology because sometimes someone will say, I have acid reflux. Go figure. They are using maybe a seasonal allergy spray, like something that's steroid based for asthma or seasonal allergies, bronchitis. And that seasonal allergy has steroids in it. And steroids will increase the risk of candida, yeast in the esophagus. And yeast in the esophagus will give you the same symptoms of acid reflux, just like someone who, so if your doctor doesn't always check and look at your medications and say, hang on, what are you on? How long have you been taking it? Are you started? Did you just start a steroid? We have to think about candida. Maybe this, and they just give you that PPI, or you yourself just go to the pharmacy and just like, oh, I'm just going to take a PPI. Well, you could be taking an acid blocker medication that's going to be causing low stomach acid and then feeding yeast. So not a good solution. That's why you need to see an expert. That's why you need to see a specialist and not just start doing whatever. Okay, so very important there. So all of these testings, we can measure your acid levels over 24, 48 hours, 48 hours. I do a lot of that testing. We can also measure something called impedance, which tells us about flow. How are things flowing through that esophagus? Are things clearing? Is there an issue? We can check for pressures, for other causes of reflux. And then we can actually offer surgical approaches, right? All of these things are helpful to try and understand pathophysiology, but they don't help us understand root cause. And that's what I learned over the years, right? Sometimes you need them as solutions, right? So bunch of people, 100 people show up and they're like, oh, I have acid reflux, Dr. V, scope me now. And I'm like, sure, I'll scope you now. But when I scope them, even with those who have very severe forms of acid reflux, like they're really mentioning, like, I can't eat, I can't sleep, this is horrible, I sit up in a chair with pillows, only 30% of them will actually have evidence of acid reflux on the scope. Evidence being they have ulcers, they have scratches, erosions, or they have something called Barrett's esophagus. And Barrett's esophagus is when the cell lining actually starts changing to protect itself from acid reflux. The cells in the food pipe start looking like the cells of the intestine because they're trying to protect themselves from the acid. They're trying to become sturdier, right? So 70% of patients who get an endoscopy, it's normal. And very often patients are very frustrated. They're like, what the heck? Like, I have really bad acid reflux. What do you mean my scope is normal? That's why the scope is not necessarily the best first test. I know patients want it a lot, but I would rather spend the money and spend the time. Imagine the money you have to pay for a scope, almost $1,200 for those of you who have high deductibles. Spend that money in investing in nutrition, lifestyle, educating yourself, getting the coaching, figuring out what else you can do from a more holistic standpoint, trying to get to root cause, than doing a scope. Most GI doctors, and I love GI doctors, I'm a GI doctor for life. I'm not bashing my colleagues, but we overscope, especially when it comes to EGDs. We don't find anything we overscope. But there are some patients who need that scope, right? They're gonna be higher risk patients. Family history of acid reflux, family history of esophageal cancer. They've had inflammation on previous scopes before. They have Barrett's esophagus. Their symptoms are out of control. You definitely want to take a look and see what's going on. You want to see if they have Barrett's. You want to see if they have erosive esophagitis. Because I will say this, and I am reported, these two etiologies, these two causes, you need a PPI. No ifs, ands, or buts. There's no amount of turmeric, ginger, peppermint, chamomile, or fennel that's going to fix Barrett's or erosive esophagitis. Because the benefit of the PPI is not just to reduce acid. And of course, you want it short term if you can. But we know that actually acid blocker medications like PPIs, proton pump inhibitors, that is Nexium, that is, omeprazole, pantoprazole, actually have an anti-inflammatory component. When you give someone an acid blocker medication, you take biopsies, you take their tissue, and there's a ton, and you'll notice that if you compare the before and after, it's not just an acid blocker issue resolution, but we actually see the amount of inflammation reduces. So that in a way is some kind of indirect benefit of the acid blocker medication. It has its negatives, we know that, but it has its positives. And since acid blocker medications came to the market, like omeprazole, pantoprazole, we see less deaths related to GI bleeding from ulcers. People back in the day used to actually die from stomach ulcers or esophageal ulcers, but PPIs have actually helped minimize that and reduce inflammation. But the problem is that there's overuse and abuse. And that's what we'll talk about. So some patients need that acid blocker medication, that PPI, and we just have to know what the indication is. But 70% of us, myself included, and I'll show you why, we can get away with doing a lot of other stuff and not having to take these medications if we can identify root cause, okay? If we can identify root cause. So there are some people who, I was talking about GIs over scope, that is true. And GIs have to remember, we have to remember who to scope. So it's really important that our primary care doctors, our internists, our ER doctors, and our nutritionists, dietitians, seeing patients with acid reflux, understand when you need to refer a patient. Right? If someone is over 60, never had acid reflux, all of a sudden they have acid reflux, they need to see GI, they need a scope. Someone having chest pain when they're doing activity, that's not acid reflux, right? That's cardiac. They need evaluation. Someone who's losing weight and has acid reflux symptoms without even, they're not trying to lose weight, they're just melting away, could be cancer, need evaluation. Someone who's actually actively choking, they can tell you, when I eat this piece of turkey chicken, it gets stuck and I'm choking and I feel like throwing up. There could be something that we need to go in and dilate. We need to stretch the esophagus because there could be rings there, and we need to see what's going on. Someone who vomits blood or coffee grounds, they're bleeding. something else is going on. And someone who has red or black stools, so red, bright red or black tarry stools, needs evaluation, needs to see an expert. We can't do anything about that. So this lady actually is like a classic patient I see in the office. And this is the reason why I started doing all this research, because guess what? I couldn't answer their questions. They were like, why? Why do I have acid reflux? Why do I have acid or non-acid reflux? Like, what's going on? I know I gained some weight. And then some people feel like, you know what, I'm getting old. You know, when I was in my 20s, pizza, chips, fried chicken, never a problem. Why can't I eat those things now, Dr. V? And then some people like smoking, vaping causes acid reflux. They didn't realize that that causes acid reflux because smoking and vaping, that sphincter we talked about, that lower esophageal sphincter, it relaxes that sphincter. So everything just passes up and down. So smoking and vaping, same thing with greasy and spicy foods. And then they're like, what do you mean I can't have coffee? Since they have to know coffee causes reflux. My GI doc never said anything about sugar and carbs. What do you mean sugar and carbs? Yes, high sugar, high carbohydrate will make acid reflux because those things will sit in the stomach for a little bit longer, cause more acidity, right? High carb foods cause more acidity, cause acid reflux. Some people have food intolerance. They don't know what foods it is. Some people have histamine, high histamine food intolerance, and they're trying to figure out, you know, hey, what is going on? I have this high food intolerance. I'm sensitive to specific types of foods. And when we identify, they all tend to be from the histamine, high histamine liberating or producing foods. And that's a click into root cause. Like, what else is going on in the microbiome? And then people are popping ibuprofen. People are taking a leave. People are taking aspirin, even the aspirin 81 milligrams recommended by your cardiologist or the 325. Some people are more sensitive to that, causing acid reflux, right? And then the final question, and then the osteoporosis meds, guys, we've heard of things like Fosamax, right? That's why they tell you when you take it, sit upright for 30 minutes. You can't lay down because that will decrease that sphincter pressure and cause reflux. And then the final question is like, people are like, oh, come on, I've been on these medications for so long. What's next? What's my next step? Do I need surgery? I have a hernia. Does everyone with a hernia need surgery? Great question. And we'll dive into that. So when you go see a GI doc, primary care or whatever, the first thing when you have acid reflux, as what the insurance company is telling us to do, they say, give a PPI. Go ahead and give a PPI, 8 weeks course. Most of the time we go for the strongest thing. We're like 40 milligrams, I've given PPI. But that's called a PPI trial. But do you know that the PPI, if you have relief on a PPI, it doesn't necessarily mean that this is GERD. Just because your acid reflux symptoms got better because you took the acid blocker medication doesn't mean that you have GERD. You could have gastritis. You could have SIBO, bacterial overgrowth. Do you know last week I had a patient who had celiac disease? Her only symptom was acid reflux. That was it. It would have been wrong for me to give her just a PPI and do no other testing. So, you know, although this is the trial to see if this is GERD, it is such a bad test. Why do we trial a patient with a prescription already, right? Like we don't do any testing, just give the PPI, if it's PPI, well, that's it, right? It could be so many other things because it's like giving someone steroids. If I have back pain and I have IBD, like Crohn's, and I have gout, and I have, I don't know, Sjogren's or some lupus. If you gave me steroids, would it work? It would work, right? So it's covering an array of things, but it's not necessarily specific. Now, the trouble with that is that people feel better because, remember, guys, what did I say? It has an anti-inflammatory component to whatever's going on. So it will band-aid symptoms for you, but you're not getting to root cause. And as it band-aids symptoms and you're like, whoa, I can now eat that barbecue brisket without symptoms, you'll think you're good. Oh, let me just take this. But something else is still brewing that you haven't identified, and you're just band-aiding the symptoms, right? And we'll talk about what those things could be. But the PPI trial relief is not always diagnostic of GERD, even though you feel better because you took the medication. And then once you take the medication, now you're stuck on it for life. Like, it's like, well, you're stuck on it for a long time because when you try to get off, I don't know how these people with pharmaceuticals made their meds, but once you get off it, when you try getting off it, it's so hard. It's so hard, right? So does this mean that increased acid is always the issue? It's not. It could be low stomach acid, but your PPI will reduce inflammation and give you some cover, some coating, right? And so it's things to think about when it's not acid reflux, right? So GERD is not always, it's almost never caused by the production of too much acid. You guys remember that schematic I showed, and I'll show it again, 9 different things that cause GERD, only one of them was too much acid. Yet our default medication is the PPI. We treat all of those causes with one drug, PPI. It's like putting everybody on steroids for the same thing. So just something that I started thinking about as a gastroenterologist, like, how can I do better for my patients? How can I get them off these medications? Like, what else can I offer, right? Again, I wanted to show you this again. Pathophysiology does not equal root cause. These are all the reasons why we give everyone boom, boom, block the acid. So even though things may still reflux, it may not be acid, but you don't feel the burn. That's Band-Aid. You may still have reflux because saliva is not exiting well, your esophagus is not clearing well. So you've numbed the acid. We've turned this from red to green, but that doesn't mean the fluid is not still going to accumulate just in case you have a delay in stomach emptying, and that's the problem, right? You're still going to have that delay in stomach acid. The PPI, the acid blocker medication, will not fix that. So unless some of these issues are discussed and addressed, we truly are just doing a Band-Aid. Now, PPIs work for some, definitely. If you have erosive esophagitis, if you have Barrett's, if you clearly have a weakness here, it works, but not for everything, okay? Not for all the causes. Let's talk about low stomach acid. I did a lot of research on this because, I don't know why conventional GI don't believe in low stomach acid. I mean, if you can have high stomach acid, you can have low stomach acid. So as a gastroenterologist, what I do is when I scope patients, I go into the esophagus, go into the stomach, and suction juices. I just suction what's in there. And then I just ask my assistant to just place a litmus paper, dip it in, and tell me, is it acidic? Is it alkaline? Is it a pH of 0 to 4, which is acidic? Or is it a pH greater than 4, which is alkaline, which is not what should happen in the stomach? And in the beginning, when I started doing that, I was like, is this even science? I was like, let me just try, right? I said, I need to find something. I need to discover what's going on with this patient. And I've done this over years where now other GI doctors are doing the same thing. They're like, oh, we want to do what Dr. V does with that litmus paper stuff. But I have seen it to be consistent. So all of my patients taking a PPI, an acid blocker medication, who took it even the night before their procedure, very often when I test, their pH is greater than 4, meaning even just with that test of that gastric secretions, I can see they're not producing acid, right? Because the PPI is suppressing. And then you have a few patients who they're not taking acid blocker medications, and I test, and it's like pH of 6. And I'm like, whoa, they're not making any acid at all. And guess what? They have acid reflux. Well, reflux symptoms. They have exactly the same symptoms as someone who you would normally just put on a PPI, that the insurance would say, hey, just put on a PPI. But what we know is that low stomach acid is not natural. God did not create us with the goal of having low stomach acid. There was a purpose to the acid in the stomach, right? The acid actually kills bad bacteria that you ingest, like you put your finger thing in your mouth, or you lick something, or acid goes in your belly, bacteria goes in your belly, parasites go in your belly. The acid there is it's very acidic. Between 0 and 2 is where most people live. That's very acidic. And that acid is supposed to kill bad stuff before it gets into your small intestine, right? That acid is also very important in activating digestive juices. Digestive enzymes made by the pancreas, they need to be in an acidic milieu in the stomach to be activated, right? That acid is also very important for nutrient absorption. There's actually something called R protein, R factor, which helps food, which removes vitamin B12 from food. And that enzymatic reaction needs to happen in acidic environments. So when you suppress with acid blocker medications, or you are naturally somebody who doesn't make a lot of stomach acid, these are the issues we can see. Impaired digestion. You feel like stuff is always sitting in your stomach. You feel full all the time. You feel like stuff isn't moving down very well. You just feel queasy and that you just aren't feeling good. That it also does what? It lowers that sphincter. So low stomach acid and high stomach acid will weaken that invisible valve we talk about, Well, so then you'll just have stuff going up and down. It's not acid, but it's stuff going up and down. It will cause microbial overgrowth and lead to issues like dysbiosis or bacterial overgrowth, like a SIBO or SIFO, bacterial overgrowth, right? Because acid is not there to kill. It will slow down stomach emptying. Acid has that role as well in terms of improving motility. So low stomach acid, slow down motility. And then you'll start noticing that your absorption of certain nutrients are altered because your stomach is not making enough acid. So this can happen naturally, but this we see happening more often than not when patients are taking long-standing acid suppression medication. I'm not talking about just 2 weeks or 3 weeks. I'm not talking about a 10 milligram or 20 milligram dosing. I'm talking about consistent use for months and years and years and years, and 40 milligrams. And one of my patients last time, she told me, my acid is so bad, I take the reflux medication 3 times a day. I was like, what? I said, what dose? She said 40 milligrams. I said, you're taking 40 milligrams 3 times a day? I said, I'm the problem. I haven't found your root cause. And obviously something is not working. So really important. I think this notion of low stomach acid is very often poo-pooed by our conventional gastroenterologists, but I think we are realizing that it's more than just that. Okay. All right. And then this is where I feel like I can sync everything, that it's not just a regurgitation problem. These are some of the issues that functional and integrative medicine highlights when we're working with someone with reflux issues. It can be an immune issue, leaky gut, eosinophilic esophagitis, meaning immune response to foods. Celiac disease, I told you guys, can cause reflux. That's it, just reflux. They don't have diarrhea, nothing, just reflux. I'm surprised by the number of my patients with ulcerative colitis and Crohn's disease who need a PPI. They say I have reflux, especially when their disease is not under control. And that's because it's one long tube, guys. From mouth to anus, it's one long tube. So you've got inflammation in the small bowel, you've got inflammation in the colon. All of that perpetuates to leaky gut and comes all the way up top here. So they're not two different issues. Hormonal. I'm pregnant. My reflux is worse, right? I'm stressed out. My reflux is worse all of a sudden, right? I'm perimenopausal. I'm bloated. I'm constipated. My reflux is also worse. There's a hormonal component. If I'm wrong, you guys let me know, but there's clearly a hormonal component. Vagal motility. We talk about the brain-gut axis, BGAD. There's an issue with the vagus nerve. For whatever reason, that's where we have to identify the root cause. There's a microbiome issue. You've got SIBO, you've got SIFO, you've got some weird parasitic infection. SIBO being the most common ones, cause acid reflux. So, and then structural, a hiatal hernia. This is physical, it's mechanical. You were born like that, or you gained weight and your stomach is pushing up, or there's some diaphragm issues. So no, it's not just a reflux issue, right? So that's where we get into root cause. All right. And I'll take a minute so you guys can look at the slide, kind of digest the information that I've shared. And I promise to share with you guys what I found as solutions for my patients, what programs I've put together that I feel help my patients, especially when we get to that place of, what am I going to do next? What else? What else? What are the options for me? So guys, hang in there. I promise to share what we have discovered, the strategies that we are using, and some of the results we see. So hang in there. Food sensitivities, we take a look at. Hypochlorhydria becomes a question. SIBO, is it SIFO? Is it self-infection parasites? Are we looking at hormone imbalance? These are all true root causes for which we need conventional and specialty testing. But these are things that your docs need to start thinking about. Why are you having this reflux? Why is this issue going on? Why is it persistent, right? So let's go into cases. Let's call this chick Coco. That's me. 31-year-old fellow, GI fellow. When I was a GI fellow, I've had GERD as a kid. I told you guys, I would puke in my mouth all the time. I mean, my brothers were like, oh, she's puking again. I didn't even know what it was. I didn't tell anybody, but over the years, I've grown up in a family where we eat extremely spicy foods. And then as I started fellowship, medical school and fellowship, it was the usual for me to eat in a rush. I was like, I got 15 minutes, let's go. I would eat late because I would study late at night. I would be studying till 2, 3 a.m. And that's when I would eat. And coffee was like my water. I would drink whatever. If you offered me coffee 10 times a day, I would never refuse coffee. And I thought sleeping was for suckers. Like I just didn't sleep. I was fine on 3 hours, and I was very proud to say that, oh, I only need 3 hours sleep. I'm good. I'm all good. So PPIs became a must for me in fellowship because I had such bad acid reflux that I ended up in the ER one day with chest pain. And I was very worried that I was having something called aortic dissection, like the worst vascular problem you could have. I was like, I'm dying. I have aortic dissection. And I went to the ER. I spent hours there. They did all this testing only to say it's acid reflux. And I felt like a wimp. And I left, and they put me on Nexium. And I just started taking that every day. And I took it even as I was like, well, I need it. I eventually got an endoscopy, and they said I had NERD. I was in that 70% that had no signs of any erosions or ulcers on my esophagus. But my GI doctor said, you just got to take this medication, V. That's it. Just take the medication. You'll be fine. Take it every day. And I felt good on it. So I was like, oh yeah, I'll take it every day. No problem. And he said, your hernia is too small. We don't need to fix it. Like, it's fine. You're okay. And I was very skinny back then. So it wasn't like a weight issue, right? But skinny people have hernias. Big people have hernias. It's not like a big person's issue. Okay. And my vitamins were low. My B12 was always low. My D was undetectable. And then I was always bloated. When I started that medication, I took it every day religiously. Sometimes I take it twice a day because I had such bad acid reflux. And I noticed that I was getting bloated and bloated all the time, bloated. And nobody told me about diet and nutrition. They really didn't. I mean, although I learned it in fellowship, like they didn't emphasize it. So I was like, oh, let me just take the Nexium. I'm good. But I noticed that as I needed double dose of the Nexium, my bloating would get worse. And on the days where I skipped Nexium, my bloating was better. And I was wondering, what's this about? So that is Coco. That's my alter ego's name, Coco. And that's what I went through. But I want to share the example of Mark. Now, this is a patient I saw in 2022. Yeah, early 2022, 2021, just kind of around that COVID time. And he's a 58-year-old educator. And he came to me as a last-ditch effort. He had already seen 4 GI doctors and had multiple scopes. You guys will see. And I was his last-ditch effort because a friend recommended that he see me and just get a second opinion before he goes under the knife. He was going to go get a surgery. Now, in some patients, surgery is needed. Don't get me wrong. This is where I differ with traditional, like holistic. I combine both. As I say, when your leg is broken, do you want an orthopedic surgeon or do you want turmeric? If we need to fix a severe hiatal hernia that is causing reflux, aspiration pneumonia, making you need the acid blocker medication 2 or 3 times a day, then you need surgery, right? You absolutely need surgery because this has gone above. This is a mechanical issue that needs surgery. And that option has to be proposed, but everything has to be done first. Now, Mark was one of those guys who would just throw up. He would not, he said, I don't even have reflux. What is heartburn? I don't know heartburn. He would just puke. It was like, bleh. He would just puke everything, right? Puke several times a day. He would just run to the bathroom and he would just puke. And this was a bother. He was an educator. Actually, he was a music instructor. And this was a bother. But he started having stomach pain, bloating. He said, this reflux has just made me feel uncomfortable. I'm not doing okay. The medications don't make me feel good. And in his history, he had a reaction to milk. As a child, I had a reaction to milk as well as a kid. He had reflux, he had sleep apnea, but he did not think that the sleep apnea machine, the CPAP, was sexy. So he wasn't going to use it, right? He also had low testosterone, so that was seen on his lab work. And he had insulin resistance issues, right? He was about to get diabetic or pre-diabetic. He had gained 25 pounds over 5 years. And he said most of the weight gain happened in the 2021 during the COVID time. He still exercised about 3 times a week doing jiu-jitsu, and he still ate out 3 to 4 times a week. He said the food triggers were bread or meat. He was not able to make the correlation between his reflux and his vomiting. He really thought he had something else going on. Like he was, the hernia was twisting and then he would throw up, or that he was sensitive to specific foods and then he would vomit those. But he took the PPI because he felt like it helped about 50%. So they were a must for him. He took the PPIs. And so he needed solutions. And he was like, so I just started looking at all his data. He had 3 scopes. And his scopes actually showed erosive esophagitis. So I was like, you're kind of the guy who needs that PPI right now. And his scope also showed Barrett's esophagus. So I was like, I don't know. I said, Mark, I don't know if we're going to get you off these medications. You look like you need this, right? He also had a hiatal hernia, a little bit larger than mine, 3 centimeters, but not huge. So I actually ended up doing an EGD. I did the last one, the EGD with Bravo, where we can actually measure your acid level in your esophagus, because I wanted to see if this was an acid issue, because if it was a non-acid issue, then I had to address root cause. And his Bravo study that kind of come back positive. And he said, Dr. V, I still don't want surgery. So we did all the additional testing that a specialist would do, which is why it's important, guys, to see someone who can understand the fundamentals of the pathophysiology of reflux disease. I did an ultrasound to check his gallbladder. I did a gastric emptying. He struggled with diet. His doctor gave him a hand sheet and said, just go eat this. And he couldn't do it. He tried a bunch of supplements because his wife's friend was a nutritionist and she had recommended all sorts of things like DGL and Gaviscon and slippery elm and things that we know work, digestive enzymes. But he took them all at the same time. There was no structure. And so he was taking like 10, 15 supplements. And I think he was actually even sensitive to some of the capsules and the gels in the supplements. So there again, with supplements, it's not just like, oh, just take this and you're all good. Those can also cause issue. So be careful. So the GI doctor he saw before me basically said, PPI for life or fix the hernia. And for him, neither were an option. He said, I'm too young. I'm not sure this hernia fix is going to work, because 50% of the time, people who get a hiatal hernia repair 5 years down the road may get back on a PPI. It doesn't always work, and it doesn't always work perfectly. But in some patients, it does, or they end up needing less of a dose, which is good. He had the sleep apnea, so we had to address that. And he had a low T, but that low T was most likely from insulin resistance, right? So our integrative approach, and this is what my promise was to you guys, to kind of share over the years what I have adopted in my patients who are seeking more, who want to go all the way deeper into root cause and really figure out what's going on. Patients who are ready for lifestyle change. It's really important that I work with people like that. And these are the people that I present my solution to. I'm presenting it to everyone today. There's some patients I see in clinic and they're like, Dr. V, just prescribe my PPI. And I'm like, but what about diet? What about, let's talk about, they're like, just prescribe my PPI. And I leave those guys alone. I don't try. I mean, I try, they didn't listen. So I just leave it, right? They just want the PPI. And I get to a place sometimes where I say, you know what, I'm only willing to prescribe this dose because I just don't see you're making the commitment in terms of lifestyle and nutrition. But in some patients who have, you can just tell they need a deeper look, right? That's where we put together these pillars. I put together this 3-pillar approach from my training in functional medicine, from my training as a certified gastroenterologist, to see how I can go deeper to help patients. And I focus, number one, on nutrition, because I feel that's where people need the most help. Some people just don't even know that peppermint causes acid reflux, or chocolate makes the reflux worse, or cacao mixed with a chocolate, chocolate bar that has cacao will make your reflux worse. I didn't know oatmeal did it for me. Oatmeal, forget, worse reflux, high carb. The carb load was just too high at one sitting for me, right? So I really worked with our dietitians to focus on nutrition, right? Putting them on a therapeutic diet. We start by analyzing what they're eating. We then put them on a therapeutic food plan where we're removing and replacing, right? And then we try and diversify in order to reset the microbiome. And then we go a step further into root cause testing, right? We look at what the imbalances are. Like with Mark, he had a low T, he had insulin resistance. None of that had been tackled. We checked him for H. pylori. We looked at some other testing. We ended up doing SIBO testing, stool comprehensive testing to kind of see where his microbiome was at, make sure there was no other infection, like a parasitic infection or an imbalance in the microbiome, at least a basic imbalance in the microbiome that we could see. We wanted to heal the gut function. And then we focus, our 3rd pillar is lifestyle for prevention, right? Identifying the stressors. And Mark didn't tell me straight ahead, like from the beginning, but he was going through some challenges at work. that were keeping him up late at night. He was stressed out. He was barely sleeping and he had sleep apnea, right? So developing some coping skills, some therapy, actually encouraging patients to go for therapy, right? It's not uncommon that our patients come to us and going through this really stressful time, and I don't know if that's affecting my reflux. It is. It absolutely is. So unless you confront that and address it and try and reverse the situation or find coping mechanisms, it's difficult. And then trying to maintain a balance, right? Trying to maintain a balance amongst everything, with everything going on, so that the diet doesn't become too stressful or too boring, so that the root cause testing, you understand what you're doing and you're well aware. So that is the program that we found really helps our patient. It's like we dive into everything one by one, because this is tough. How am I going to figure out if there's impaired mucosal defense? There's no test for that. You know, there are a couple tests for pyloric incompetence, but extremely uncomfortable test, right? So it's really hard. But when we dive into root cause, we figure it out. I put this on just to make sure you guys were still alert and awake. That's my daughter and my niece, and my surprise at Mark's success. Super surprised. As a gastroenterologist, I was actually surprised because I was like, this guy's going for surgery. He's going for surgery, that's it. So I reviewed all his labs, as I said, conventional studies, make sure everything was done. We weren't missing something, right? I wasn't missing a gastroparesis, delayed stomach emptying. I wasn't missing a candida esophagus. And then I looked at all his labs, and he did have some micronutrient deficiency. I think his magnesium was low, his B12, his D was low, so we repleted all that. His SIBO test came back mildly positive. That's a test for bacterial overgrowth. And so we said, well, that's fine. We want to reset his gut first. And so we worked with the elimination diet, and he committed. He stuck to it for a while. We looked at his stool studies and addressed the issues in the stool testing, did permeabilities testing. He wanted to go all the way. We focused on his insulin resistance. He ended up doing intermittent fasting. He used the sleep apnea machine, the CPAP, and it helped tremendously. So we put him through our standard 5R protocol, replacing nutrients like zinc, giving him enzymes, helping with healing at the appropriate stages, so he wasn't dumped with a bunch of supplements all at the same time, so he could tolerate it. And at week 12, which comes towards the end of our program, I was blown away. He had lost 30 pounds. His wife had lost 15 because she did the program with him. He had more energy. He hadn't thrown up in 2 months. So we started the program right when he got on the nutrition plan. He stopped throwing up for 2 months. And it was hard for me to keep him on his PPI because he went from 40 milligrams almost twice a day to 20 milligrams twice a week. And that was me forcing him to take it because he had no symptoms at all. The vomiting had stopped. So I wanted to be sure. I went back in and I scoped him. 6 months later, all the erosive esophagitis, and this is literally, this guy probably didn't even use the PPI 10% of the time. I think he just said it to make me happy. 50%, all the erosive esophagitis, I mean, his esophagus was clean, but he did have Barrett's esophagus. And that's why I kept him on the PPI. And this is why I want to alert you guys that it can't always just be fixed with supplements and nutrition. There's some instances where that anti-inflammatory, anti-acidic component of a PPI is necessary for some patients. So he had Barrett's esophagus. So what we decided to do was we wanted to test his Barrett's. And now we wanted to see whether he was a high grade. He had a high risk of transforming into esophageal cancer. So there's a new test that came out a couple of years ago called the TissueCypher. And the TissueCypher actually does like proteomics and genomics to look at the tissue and actually analyze the DNA and see if this patient is going to be high risk for Barrett's esophagus cancer, esophageal cancer or not. And if they're low risk, then the PPI, whatever, because even the studies are showing that PPIs do not necessarily prevent the risk of cancer formation, right? So with him, we did the TissueCypher and he was low risk. And I was like, this is great. If he was high risk, I would have probably committed him to a PPI for a little longer. Why? Because that is standard of care in the American Gastro Association guidelines, right? Now it's up to patients to decide what they want to do because the data is skewed. But he decided, okay, he'll take it a couple times a week, and that was it. But off PPI, to my surprise, He did great. He lost weight. He had energy. I saw him 6 months when I did his endoscopy. He had still kept the weight off. He had gone back on a food plan that was modified, that our dietitian had worked with him. His sleep was so much better. And, you know, I was the one who was the most dumbfounded because he didn't need surgery. He did not have to go through with surgery, and we were able to wean him down. So that was a success for him. So going back to, it's not always just a regurgitation issue. There are many, many issues to address. Oh, and by the way, his testosterone levels went up as he lost weight. The one thing he reported when he came in is like, my sex drive, Dr. V, much better, right? That's the one thing, that's the first thing he reported. So an integrative solution is what we offer in our program, the detailed evaluation by GI, dietitian, root cause testing beyond just the basics of an EGD, nutrition support to see what diet you need to be on. We actually call it a therapeutic food plan, and address, don't ignore lifestyle components. You must address the lifestyle components, not just nutrition. There's a huge component of lifestyle. And in our program, that's what we do. We work on the 3 pillars. We see our patients twice a week, right? For coaching, for teaching, for education. So you're getting your information from the right places. And we see a lot of success. So in terms of nutrition tips, there's so many. I don't even have to go into so much detail. In terms of nutrition tips, you go on ChatGPT, supplements galore. They tell you everything you can take, right? So you don't, that was not the purpose of this discussion. Here, I really wanted to go into detail as to what are the root causes of reflux and why does your doctor have to think about different things. But what I have done for my patients in terms of natural supplements, I use Gaviscon, the seaweed alginate, the Gaviscon Advanced, not the one from the US, but the one from the UK. I use pro-motility agents like DGL. Lozenges work well. They pop them like Tums and can help relieve symptoms. I use mucilaginous supplements that will help coat the lining of the esophagus, very often combined with zinc carnosine, which in many studies, many articles has shown to have healing benefits for leaky esophagus and leaky gut. I use enzymes to help digest better. I use melatonin, helps with the motility. Melatonin actually has a direct impact on that sphincter. Alkaline water depends on the quality of the alkaline water. I have recommended acupuncture to my patients, and it has helped their reflux significantly, and vagal nerve rebalancing. And then in terms of food, we've talked about it, right? We've talked about the diet. The ones that are known to provide the longest term relief, scientifically speaking, is the Mediterranean diet, as well as the elimination, doing that for a while. And that's what we did with Mark. And then general things like head of the bed elevation, mindful eating, avoiding these foods. Remember carbonation, remember carbohydrates. I think those are often the 2 that are forgotten. Having a customized plan. If this is sort of like, I'm getting to the end of my rope here, what do? We offer a therapeutic food plan so that you're not lost, perplexed, confused about the data that's out there. There's a lot, it's complex, guys. You see, it's really complex. And we don't want people to be restricting foods forever. Like, that's just not a good solution. Nobody wants to live like that. You'll rebound, right? We don't want you popping 10 different supplements because you don't even know which one is working. We want a strategic and methodical way to introduce supplements. And we certainly don't, I didn't want to take a PPI for the rest of my life in my 30s. So I have not used a PPI. It's been 5 years now. I have not touched a PPI for 5 years, but I took a PPI for 5 years. So that goes to say that even someone like me who was, I felt like it was my drug. Like I was like, that is for me. Someone like me who took a PPI for 5 years was still able to get off a PPI, even though I had been using it religiously for 5 years. So there is a method to this. There is a way. Now, it works for most, not necessarily for all. So I want to be very clear on that. Don't feel like because you couldn't get rid of your PPI or because you were able only to wean down the dose that you are a failure. No, everyone's system is different and everyone's root cause is different. So trying to get to the root cause without struggling. And so this is what we do in our program. This is what has helped me look and help my patients beyond just conventional gastroenterology. I really felt I needed to be able to answer some questions for some patients that were really important to them, and they were seeking long-term solutions. And so we offer this online program that we have, well, a lot of it is some of it is one-on-one that we have crafted over the years and we know has worked with the guidance of our functional medicine training, the guidance of excellent dietitians. This is the program that we have put together to really provide patients with a solution. And so this may speak to you because you know someone, you have a friend, you have a family member, you have a patient that is really battling with reflux, and you're trying to get to root cause, and they've been scoped and nothing's been found, think about whether you've really identified the root cause. Have you looked into everything? Have you referred them to someone who knows, who can do the tests, who can do the specialty testing, provide guidance? Because this really is a walk with the patient, right? It's really, you're supporting them throughout the process like we did for Mark. And so if you know someone or yourself are ready to really say, you know what, I'm done. Like, I want to give this a chance. If this is my only chance at getting off PPIs, or this is my only chance of feeling this way, type in ready in the chat. We will set up a time. We will have a free call. We'll figure out if we're the right fit. Maybe you've already done all this stuff and you're like, whatever she's talking about, Dr. V, right? But typing ready in the chat, READY, and let us know if you want to get on a free call, and we can actually just have a quick conversation about whether we think you'd be a good fit or who you think we would be a good fit with. And I think this is the future of medicine. This is where we're going. Our focus is wellness and not illness. Our focus is prevention and not committing you to a medication every day. So I hope I was able to answer some questions. I went over my time again, and I apologize. More information on our Facebook group, Natural Gut Relief. If you're not already a part of it, please join. We are located in Katy, Texas. I thank you for listening. And I would love to hear and answer some questions.